All right. Hello, everybody. Welcome to the next session of Virtual Global Spine, hosted by yours truly. I wanted to spend tonight giving some updates on cervical disc replacement, kind of like give an update on where we stand now in 2025. Because, again, this is a topic I've talked about quite a lot, arthroplasty, and I would like to think that the field has really progressed forward and has really changed a lot since um, probably the mid 2000s when we started using these discs. Uh, but really, not much has really changed. I mean, there are some new implants on the market now, particularly with more of the unconstrained implants. But in general, to summarize my talk before I even get into my talk, there's not that much that's different. Now, if we give a hypothetical patient, right? This is like a very typical patient I see in my office. And it's a young 30 mid 30s person who has significant neck pain with left upper extremity radiculopathy. Okay. And on this MRI, the patient has a 5/6 disc herniation, right? It's all in the left paracentral disc with compression of the exiting nerve root here. Patient has a C6 distribution radiculopathy, right? We have a couple of different options. So assuming that we're going to go, one is obviously a posterior cervical foraminotomy and discectomy. That's an option, right? The other options are an ACDF, and this can be done with, let's say, PEEK or titanium and a plate, or this is allograft and a plate. It could be a standalone ACDF, right? And in this case, this patient has a PEEK with, I think this is the DePuy system, but it can be a standalone ACDF, or it can be a total disc replacement, right? So we basically have three options. We have an ACF with a plate, standalone ACF, total disc replacement, or a posterior cervical foraminotomy. So we actually four options to treat this patient's radiculopathy. Interestingly, when I was early in my practice, I would always do this option here. I would always do an ACDF with a plate. As I matured in my practice, this is not my ACF, by the way. This is just taken off the internet. um, as I matured in my practice, I moved more towards standalones. And then for some period of time, I started using the total disc replacements. And interestingly, now I do pretty much, I'd say 50% posterior cervical foraminotomies and 50% total disc replacements. So I very rarely do ACDFs for these indications now. Why? I don't, and the answer is I can't really tell you why. It's because a couple of reasons. One, I've been so ingrained at this point that disc replacements are good for young, healthy individuals with tall discs, with fresh disc herniations, minimal facet arthropathy, good disc space height, right? This was like, for all my residency, oh, disc replacement, disc replacement. This is great. This is fantastic. You go online, you see all these, pictures of these guys like golfing and, playing hockey. Oh, disc replacement is the greatest thing. I got my get your life back, this kind of stuff, right? So I really thought this was the thing, right? There were some papers out there that I read at some point. I couldn't even remember them, who the authors were, what they were. Somewhere in my mind, I read that, yeah, it's a less risk of adjacent segment disease, right? So it makes sense, right? If there's less adjacent segment disease in a patient that's 36, if, this patient's going to be living, let's say, until 80, for example. So you're talking about 50 years with that implant. You really want to reduce the risk of adjacent segment disease because, especially with an ACDF, it's significantly higher, significantly higher. So yeah, we want to do that. We want to put a disc replacement in there, less risk of say just segment disease. And these patients do better with axial neck pain scores and so on and so forth. And you maintain a segmental motion. There's less risk of kyphosis, things like that. So it seemed really, really good. So I was like all in on this. As residency continued to go on and the more of the long-term data started coming out, a lot of these things that I thought were like tried and true, it was pretty obvious. Oh yeah, disc replacement's great, disc replacement's great, right? A lot of things didn't really pan out in 2020, like today in 2025. And I would say there's pretty much equivalence between ACDF and a disc replacement. There's essentially no difference in terms of outcomes, and there's no difference in terms of adjacent segment disease. So they're basically the same. They're basically the same surgery. It's kind of dealer's choice, right? Now, Um, when it comes to post-cervical foraminotomy, that's a different thing. But that's actually, in my opinion, probably the best option for a young patient like that. You know, you can really get a good outcome. These patients do really fantastic if you're able to take that disc out from posterior. It's a very satisfying surgery as well too. So anyway, getting back to the heart of this talk, cervical disc replacement, right? Many different types of implants. Um, for the longest time, we thought this was an acceptable alternative to ACDF. And in the industry-sponsored conflict of interest studies, they show that there might be some possible superiority with the Mobi-C implant at 2-level versus 1-level ACDF. So a 1-level ACDF versus total disc replacement, it was non-inferior. At when it came to 2 levels, there may be some inclination of superiority, right? It's the exact same surgery. There's really no difference, right? Same Smith-Robertson exposure, getting down to the anterocervical spine. You put your Caspar pins in. Everything about it is basically the same. There's really functionally no difference. I would say the main difference there is positioning of the implant, right? With ACDF, you have a little bit, what happened here? With ACDF, you have a little bit more leeway, right? It doesn't have to be perfectly in a center. You're not cutting a keel with the ACDF. It doesn't have, you don't have to be as precise. I hate to say it that way because we as surgeons are extremely precise, and we have tremendous amounts of OCD when it comes to the appearance of our implants and our hardware and that final X-ray. You want that thing to look perfect, right? So we take a lot of time. But if you're a little off or the plate's a little asymmetric, fine, who cares? That's okay, right? It's not gonna change anything in this patient's life. But for a disc replacement, it could really be a big change because if that implant is fixed in flexion or extension and doesn't move, right? What have you really done? You haven't really helped this patient anyway. Okay. So the main indications are, I would say, and this is pretty much taken from the literature, right? But if you're going to pick in your mind the best patient for a total disc replacement, you're talking about someone in their 20s, 30s, or 40s, right? With minimal spondylotic changes in the neck, Paul disc, fresh disc herniation, unilateral radic with neck pain, right? These are patients who do pretty well. This is like the ideal patient for this, and they're athletic. They move around a lot. These are patients who like want to be active, right? So this is like the best patients, a young adult with soft disc herniation. There are other things that obviously, you're probably not going to do a disc replacement for someone with cervical spondylotic myelopathy. I can do someone who has a significant spondy with dynamic instability on flexion extension. These are not things you're going to typically do with a disc replacement, right? But for why is it switching? All right. But for the patient who is young, has a healthy spine, has a fresh disc, this is pretty much a good option. And these are patients are pretty frequent in this day and age. Okay, so why do we even have disc replacements, right? I mean, number one, in the with orthopedic in the orthopedic realm, in orthopedic surgery realm, um, arthroplasty is super common. It's well understood. It's superior. It's a the patients do fantastic. Hip and knee replacements. These patients do very well. So it's only natural that we want to take what we learn from and what we do on a day-to-day basis in orthopedics, and we want to bring that to the spine, right? The problem is that uh, the implants themselves are not quite where they need to be. They don't have the same level of sophistication that they do in the orthopedic, in kind of with hip arthroplasties and knee arthroplasties. These implants just are not the same. And the spine is a very different system of joints versus the hip or the knee, right? So the problem with ACDF, if you kind of look at what the problem is, when we did these long-term studies, okay, we found that the reoperation rate overall was about 10% at about 10 years. And as with anything, right, with long-term data, the success rates kind of gradually drop over time. So they became about 70% success rate at 10 years and a 10% reoperation rate. We said, okay, well, maybe it's not the best option for someone who's young, right? So you have 30, 40 years old at 10 years, they're likely to have issues, right? I mean, and remember, these are always understated. There's always more. There's always higher rate of reoperation in this typically, right? That you're going to see, and there's probably that that rate is probably lower, the clinical success rate. Okay, and what we attributed this to was a J segment disease. Said, okay, look, the problem is really the J segment disease, and these patients are developing this over time, and this is what causes these problems. Okay, and the thought is that, and basically, if you even like touch the spine, right? If you even look at the spine, there will be some level of adjacent segment degeneration at the level that you are operating on, as well as the other levels. So even doing a posterior cervical foraminotomy at that index level, right, you will develop a J segment degeneration, which is interesting. Even though you didn't even touch the disc, right? So it's very, very interesting. So it's thought that this is actually just a natural process rather than related to the surgery and ACDF itself, although that ACDF does certainly speed things along. So this is a great paper that came out last year, okay? And when we think of this, I want to bring this to the forefront. When we think of these trials, I'm going to go through some of these, looking at the differences between cervical disc arthroplasty versus ACDF, okay? There is this concept that I never really thought about before, but once you start looking into it, it's very interesting, is this concept of statistical fragility, okay? So what does that mean, okay? So when you have let's say some study out there and you're looking at the difference between ACDF and disc arthroplasty, right? A lot of these studies that exist are actually quite fragile. What does that mean? Like it only takes a couple of patients in any of those groups, right? Like it could, and this is looking at, look, and see, on average, ultimately the outcome of 4 patients, okay? 4 patients can totally change your study. Okay, so these ACDF and disc replacement studies are so fragile, and a tiny 1 or 2 patients here and there can totally change the outcome. So it's very interesting. So keep that in mind. Okay, that's number one. Number two, keep in mind that there is definitely a bias when it comes to literature. A lot of these papers, in particular with disc arthroplasty, are industry sponsored, industry driven, and uh, there is a desire, or it's obviously in their best interest to publish papers or to design studies in a way where you get possibly a positive outcome. That's not to say the study is irrelevant, but it is something to keep in mind that that these papers can be, many things can go into these papers to get a certain outcome, right? Right? These are not blinded in any way. We don't have like we don't really have an RCT where these patients are blinded. They don't know what they're getting, right? Everything's open label. The patients know what, oh, I'm getting a Mobi-C implant, one level, this disc, the surgeon knows, right? So it's not like there are a lot of things that go into these studies that can really alter the outcomes. So anyway, so going back to this, so study fragility, keep that in mind, right? Only a couple of patients here and there that can totally change the outcome of your study. And then two, these studies are unblinded, they're open label, patients know what they're getting, they're device industry sponsored, they're funded by the industry typically, right? Conflict of interest surgeons, right? So you combine those two things together, right? And poof, magic, you get these positive studies all of a sudden, right? Or you get negative studies if the surgeons don't like that. These things are hard to, it's hard to draw like firm conclusions from these things. Anyway, so, and just keep that in mind. I thought that was very interesting. I never really knew that when I was reading these studies, but it's so, these studies that exist, all these studies that exist are so fragile, and like little things here and there can totally change everything. So anyway, so if we think about the pros and cons of disc arthroplasty, what are the pros, right? So you're thinking about, all right, it preserves motion at a segment. There's theoretically less risk of J segment disease. You don't have to futz around with a plate, right? Just sometimes nice, right? This sometimes can be very futzy to put a plate on. You have to worry about the sizing of it. If you had a long day, you're kind of exhausted, you just want to get that thing on there. So you don't have to deal with that. There might be some studies that show that it might be superior to ACDF in very specific patients, right? But it is more of a pain in the butt to put this implant in, right? For the constrained implants, you have to cut a keel. It has to be perfect. You have to get tons of X-rays. You got to wear lead. Typically for my ACDFs, I'll just, my X-rays are basically, I get like one obviously I get the localization X-ray, and then I get like, and then I'll size it based on a Caspar pin. I'll say, okay, it should be like 14 depth, 16 depth, whatever. And then, I'll just hammer in my implant. I'll put a plate, and then I usually just get a final X-ray. Or if I'm a little bit concerned about something, I'll get like maybe a quick lateral just to make sure, just check the depth of the implant, and then call it a day. And I typically use a small kind of unit plate for one level. That I just use a traditional, typical like probably let's say like a 6 screw plate for like a 2 level and a 3 level. I use like a traditional 3 level plate. Um, but with my disc replacements, I'm getting many more X-rays. I really make sure everything's perfectly centered. The implant goes in correctly. It's well sized. The footprint of the implant is adequate and satisfactory. It's not too small, not too big. I'm checking all these things during surgery. It adds more time to the case. That's not a tremendous amount of time, but it does definitely add more time to the case. And I personally have not, again, I'm fairly young in my practice. I have really not seen any difference in J segment disease. I don't, in many ways, I'm a believer that a J segment disease is just deformity, right? If there's deformity that's not treated and corrected at the time of surgery, then they're going to develop J segment disease. And that has to, so let's say ACDF, for example, right? If the patient has 3 degenerative discs and you only treated one, right? The other two are very high risk. Those two other degenerative discs are very high risk of developing a J segment disease, right? That's from the Hillebrand study from many, many years ago. So I tend to be a little bit more aggressive. If I see like, a patient who has many degenerative discs and I'm planning to fuse, I tend to treat all of them. So interestingly, when I was in residency, we did a lot of 1-level ACDFs, tons of 1-level ACDFs. And now in my practice, I don't remember the last time I did 1-level ACDF. All my ACDFs are probably 2 and 3 level, right? I tend to be aggressive when it comes to treating degenerative levels. So versus my disc replacements, they tend to always be 1 level. And in very rare instances have I done 2-level disc replacements. Now, going back to what I was saying before, right? It's really incumbent on us to keep a wide armamentarium of available surgical options for our patients, right? I find that patients do remarkably well with posterior cervical foraminotomy for unilateral radic. I haven't found a better surgery for this. Even if they're very spondylotic, and even with some degree of kyphosis, I'm I have a low threshold for doing posterior cervical foraminotomy, and in many ways, I struggle to see who's a better posterior cervical foraminotomy versus disc replacement surgery, right? And I would say that those patients who have more axial neck pain tend to be slightly favor for disc replacement. Those who are purely unilateral radic, I'll always do a posterior cervical foraminotomy in those patients. And in many ways, like at least in this study, this was a JAMA article, came out a couple of years ago. It really favored posterior cervical foraminotomy versus anterior surgery, and that's primarily because of the reoperation rates, right? So these implants have been around a long time. I was surprised when I saw this because I always thought I remember they kind of became in vogue probably around 2010, I would say. Like I remember them, only a few people did them in like 2008, 2009, and then like it became pretty like, oh, the new thing in like 2010, 2011, and then like it became pretty hot in like 2012, 2000, let's say 15. And then it's kind of slowly, I think it's slowly going away. I think people are kind of going a little bit more back to standalone ACDFs and plating their ACDFs rather than disc replacements. Now, I'm just saying that anecdotally, and just kind of what I've seen in my practice area and kind of just speaking with surgeons in my area and seeing what people are doing. Now, I know that there's some pockets of places in the country that do tons of disc replacements, in particular in the South. And there's some practices that have moved like solely to disc replacement. All they do is disc replacement. They like rarely fuse these patients, which is interesting to me. But you can see that kind of takeaway point of this, that these implants have been around for a long time. I do remember that these initial implants required a keel. You had to cut this keel. It was very annoying, and Sorry, I don't know what's going on here, why this keeps happening. It was very annoying, and people didn't like this. And then when the unconstrained implants started coming in, and the semi-constrained implants like Mobi-C, for example, this became very popular because it was just much easier to put this in. You have to worry about a keel. You can just get this thing in there, one, two, three, and it wasn't much of a problem. Now, with some of the papers that have come out more recently, now this is like these papers now are very old. Obviously, from like 10 years ago. These papers were able to show like right around the mid 2010s. They started showing all the papers that came out before were all non-inferior, right? And then somewhere like 2015, 2016, we started seeing some papers that started saying, oh, maybe they're maybe possibly superior, in particular for two level versus two level ACDF, right? And we started seeing this whole rush of companies coming out and coming out with their own disc replacements. Like literally at this point, almost every company except for Stryker, I think, has their own they have their own disc replacement, cervical disc replacement. Some companies have like 18 different variations, like Sentinel Spine, for example, has like they have like 5, 6 different variations of their of their uh of their cervical disc arthroplasty implant. So what's interesting is that there was a big rush. So there's so much literature and so much data out there that I'm now starting to see patients, especially the younger, more savvy and medically sophisticated patients, will come to me and be like, "Hey, I read about this Mobi-C implant or the Orthofix M6 implant, and I saw some videos online on YouTube about that. Why can you put that one in me? I like that. It seems pretty cool because it's like it's this implant. It lets you move translationally versus so it's interesting to see patients actually come in and know this stuff. It's rapidly gaining popularity. But the thing is that these implants have been around for a long time, right? So why is there so much confusion as to what the outcomes are? They've been around for over 20 years, right? We should know by now whether these things are any better than ACDF, right? So the thing is that yes, the rates of these things have been around for a long time, okay? But all the studies that have come out have been not the best in design. And as a result, the data is just data, and it's hard to draw conclusions from this data. They've done tons of meta-analyses and retrospective analyses, but it's hard to really have an idea of why this stuff has worked or does this stuff work for a very, very long time. And the way we kind of came over that, right? The way we kind of came over that, I'll get to that one side, was to do more prospective studies, and we started looking at a propensity analysis and different types of things to kind of help tease that data and see what happened. And I'll talk a little bit later about that in this paper. But as I was saying before, right, what I found was interesting here was that when these things came out, the disc replacements, if you look at trends in usage, this was a huge explosion in early adaptation, as with anything really. In the late 2000s and the mid 2010s, we started seeing like tons of these surgeries coming out, and then as this started to get as it started to get more commonplace, we started to kind of dip off, and that's pretty typical with what we call like the Scott's parabola, right? There's like this promising idea, and there's encouraging reports. Everyone starts doing it. Oh, it's the greatest thing ever. Disc replacements for everybody. It's the most wonderful thing. And a couple of things start happening. You start getting some failures. You start getting some, heterotopic ossification. You get all these kinds of issues, and it's like oh, and it kind of goes away. And then there's this kind of this equilibrium, the steady state of like how we do this thing now. So if you're going to look at this, if you look at the data, okay, like I kind of just looked at looked at all these papers that were out there. And if you look at this, right, this is a reported 10-year reoperation rate for ACF. It's about 10%, okay, with 10% J segment disease. So I remember that 10-year, 10, 10. That's how I remember that. 10, 10, 10 for ACDF. 10 years, 10% revision, 10% J segment disease. That's what I kind of quote in my head. With disc replacement, the industry-sponsored papers came out with a lesser operation rate and less risk of a J segment disease, right? But these were not statistically significant. So there's really no difference, okay? And that fast return of prior level activity that doesn't exist either. So there's really essentially no difference between disc replacement and ACDF in 2025. They're basically the same when it comes to reoperation rate. They're the same when it comes to J segment disease, return to work, return to sports, return to activity, all the same. Now, why? We could be committing a type 2 error here, right? So remember, a disc replacement is not a straightforward surgery by any means, okay? In order to really get this right, that implant has to be perfect, okay? And it has to move, and it should not fail. It should not get locked in in flexion or extension. It should not develop heterotopic ossification, right? You really want that implant to have demonstrate movement over many years. It maintains its movement. It doesn't, fuse, right? It doesn't have issues. So the thought is that as long as that implant keeps moving, right, you're fine, right? But as we found, after about 10 years, there's a high fusion rate with these disc replacements. So they stop moving after about 10 years. So actually, Dr. Baj brought this up, which was pretty nice. He said that a good way of thinking about it is that a disc replacement is almost like a staged fusion or a delayed fusion in people. And that's actually maybe not a bad idea. So like someone who's young, you don't want to fuse them up front. You want them to fuse in 10 years. And that's not a bad way of thinking about this. And that's kind of what I like about disc replacement. So if you look at the long-term data, there's really no difference between them. But in the short term, if that implant's still moving, there is some thought that there actually might be some superiority in the data. So anyway, the thing is that as I alluded to before, the problem with the disc replacements is heterotopic ossification. So what is that? That's when the implant itself starts developing, calcification all around it. It just stops moving. Okay, and it's unpredictable on who this happens in and why this happens in these patients. And it's thought that this is really the main thing that is problematic for these disc replacements. They develop HO, and as a result, it's hard to study this because this has happened in ACFs. We call HO, we call that fusion, right? That's good. But in a disc replacement, you don't want that. So so it's hard to compare ACF and a disc replacement due to the heterotopic ossification. So we have a lot more discs coming out. The results of these longer term IDE trials are out now. They don't show much of a difference. And we're learning a little bit better technique, right? Now I just included this because sorry, this slide looks very wordy and it's hard to read. I apologize. Now the thing is that then a lot of this from before 2020. I just want to point that out. But you can see that I don't know why this keeps. I apologize. I don't know why this keeps sliding to the next slide. So you can see here that a lot of these are all the Bryan implant, Prestige, ProDisc C. That's a Sentinel implant. There's really it's all mixed. It's all over the place. Some show 10 years, better neck disability index, fewer reops, some show more, compared to ACDF or this, right? But again, you have to take all these with a grain of salt. And these are all industry-sponsored studies. None of these are blinded and randomized, So you gotta look at that, right? And the problem again with a lot of these meta-analyses, right? It all depends on the time interval that's looked at and the study fragility, what I talked about before, right? Only takes a couple of patients here and there to totally change the results of these studies. And there's really no clear, data you can draw from any of these studies. And that's coming out for a lot of the most recent studies too. Some show moved neck disability index. None of this was significant, by the way. So that's why I was saying I tend to favor neck pain and ridic, unilateral disc disease, young patient, healthy spine. That's the disc replacement. If it's just purely unilateral ridic, I'll typically do this foraminotomy for those patients, right? So as I mentioned, these are all things. Now, patient expectations, right, in IDE trials. So in the studies that are randomized in the studies that I found that were randomized, there were a few of them, there were like three of them. They were open label. That's that's a problem. Why? Because what that means is, if you look at the Nevro studies, remember the Nevro spinal cord stim studies? They came out like in the mid 2000s, or mid 2010s. Those were those were prospective and randomized studies, but they were open label. What that means is that the patients know what they're getting, right? So you can imagine, right? If they sit them down, oh yeah, we have this new implant. It's this amazing disc replacement. It's the greatest thing. It's gold plated. It's never gonna stop moving. It's gonna do everything in the world. It hooks up to your Bluetooth and your phone, and it's hooked up to Wi-Fi. It's amazing. It has AI in it, right? And the patient's like, wow, wow, oh my God, yeah, I want this, right? And then the night before the surgery, they call him, oh hey, yeah, so we're sorry, you're actually gonna get an ACF, right? So like, oh, the patient's like all upset, they're like bummed out, that like that messed up the whole study, right? Because now they get the ACDF, they're like, no, they wanted that disc replacement. It doesn't work out that way. So if it's open label, that totally messes up these studies, and that's typically how these studies are run. So you can't really draw any conclusions, right? So all these things like neck disability index are useless. These are horrible. A VAS, neck disability index, Oswestry, SF36. These are horrible, 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 terrible, awful outcomes because they're all subjective. They are, I don't know if you've ever seen these things. They are boring. They are difficult to fill out. They're redundant. Patients, I've given these things to these patients. I've seen them fill it out. They just check through it. They don't even care, right? They're not scientific in any way. They're terrible, terrible studies. So these are awful ways of looking at um of spine literature, and it's unfortunately 98% of the spine literature, right? So it's again hard to draw any conclusions. So do we have any other data, right? If you look at the large registries or European studies, which tend to have less bias, less conflict of interest, right? There's no difference, nothing came out, and this is looking at 2025 as well too. All these large retrospective databases, looking at these studies, you look at, insurance databases, excluding workman's comp, all these things, Canada, Germany, I looked at all these things, nothing, no difference between ACDF, disc replacement, no difference in outcomes, no in patient reported outcomes, no difference in revision rates, no difference in the J segment disease, no difference in anything, right? So what does that mean, right? What's wrong about these things? What did we do wrong? Why did the initial papers that came out in like 2008, 2009, 2012, they showed like superiority, but as we're looking now in 2025, what happened, right? So again, alluding back to what I said, we're still not sure if these implants are moving at 10, 5, 10 years, are those patients doing better? If they're not moving, are they just equivalent to ACDF, right? And how do we keep those implants moving? Okay, so that's kind of the key here. Let me pause for 1 second. Questions? Any questions? I can't actually see it right now. If you have any questions, just type it right in the chat box. I'm gonna keep moving because we're almost there. I'll end a little early tonight. Snowing out in New York City, and it's a cold night, so we'll try to finish this early. So the thing is that if the disc does not move well, right, before you do a disc replacement, so I typically get flexion extension X-rays, right, on my patient before surgery, right, and I get mixed results. Sometimes I see the movement there, sometimes I don't, right. If the disc does not move well before disc replacement, right, there's a very, very good chance that it's also not going to move well after disc replacement. Okay. And that's interesting because, right? I mean, if you see like a fused, like a really spondylotic disc that's not moving, I always like this idea of doing disc replacement there and maybe introducing movement to that disc space, right? Because it's kind of like, because it's the same thing in arthroplasty, right? If you have like a fused arthritic hip, if you put a you do arthroplasty there, you're restoring motion there, right? So it's actually pretty nice. So I thought you could do the same thing with this replacement, and I found the same thing. It doesn't really move very much, right? But if you have a situation where you have motion there at 10 years, there's not really too much more motion there. And if they have a lot of spondylosis pre-op, there's a higher risk of heterotopic ossification. So like, and another thing is, okay, does it restore alignment? If it's kyphotic before surgery, it typically remains kyphotic after surgery. So what about two levels? No difference. And that's the recent MobiC data that came out, right? You look at the 10-year data of the MobiC. What about myelopathy, right? So, we're looking at, okay, all these things, right? What's better? Myelopathy, right? No difference really. And maybe, if there's dynamic spondylolisthesis, right? Um, uh, you are more low to doing ACF. You don't want to do a disc replacement at those levels, right? Okay, so what about standalone versus disc replacement, right? Don't use a plate. So with this, the problem is that again, with these non-constrained implants, there's a slightly higher risk of graft extrusion or graft rotation inside the disc space. So there was higher revision rates with those versus a standalone ACDF, and there was no difference in outcomes. So you had a surgery disc replacement where there was a higher risk of revision and at that index level and no difference in outcome, right? So what do you do? So what do you do? So is it better? Is it better? Again, it's hard to draw conclusions here, right? It's always gonna be, when it comes to this, it's gonna be two camps. You're gonna have the true believers and the people who are the naysayers who, this doesn't work, I never use it, and people who say, no, my patients do great, I have the best outcomes, my implants are always still moving at 10 years. So it's hard to know. It's very hard to know. Now, this was a great study that I have always kind of fallen back on. Okay. And this came out actually, this is a Miraz paper that came out several years ago. And what they were looking, oh, sorry, I don't know why this keeps skipping forward. I promise I'm not doing it. So what they looked at here was they did basically looked at every paper looking at disc replacement and ACDF. Okay. And what they found was that the majority of those numbers that I cited earlier in my talk all came from like 2008 and 2009, when these are all mostly, and they looked at the authors and they determined conflict of interest versus non-conflict of interest, right? And if you took at all these papers, if you just removed all the conflict of interest papers, any paper where the authors could be perceived as having a conflict of interest, there was essentially no difference. So that goes back to looking at study fragility in these disc replacement ACDF. Little changes in these patients can totally change the outcomes of these papers. So basically, unfortunately, okay, so where do we stand in 2025 is that I would say this. We basically we know now there's really no difference between those two. Okay. I would go as far as saying that it's just a different option for a patient and possibly an option. Again, I don't know why I keep doing that. It's just a different option. So we have ACDF, we have disc replacement. Okay. They're essentially the same surgery. Okay. There's no difference in outcomes. There's no difference in adjacent segment disease. And there's possibly a higher risk of revision with some of the non-constrained implants as excuse me, as compared to ACDF. So when we look at that, I would argue that ACF is favored over disc replacement. Okay. But you're always going to have people who say, no, my patients they do so much better with disc replacements in my hands. These are my best patients, And if that's the case, by all means, you should definitely be doing disc replacements because there's really no difference than that of ACDF. But if you find yourself kind of struggling between, is this and should I do a disc replacement and this and that, just know that the literature and the data does not support any superiority of disc replacement over ACF. So all those things that we say are, oh, it's good, there's no difference. So with the possible risk of higher risk of implant problems. So I tend to now favor, my practice has moved a little bit more towards ACDF and foraminectomies. I do a lot more of those, and I do a lot less disc replacements. Um, whereas before I was kind of like 50-50. And with a good amount, with few foraminotomies, done a lot more foraminotomies, a lot less disc replacements, a lot more ACDFs. So let me just take a quick look because I see the chat blowing up a little bit. Okay, couple of questions. Dr. Sharivar, I believe the reoperation of ACF is much less than 10 to 12%. Yes, I would say I agree. In my personal experience, it's a lot less than that too. I'm going with the most conservative literature. I think the actual cited incident or cited 10-year rate is about 7%, 7 to 8%. But I'm just going with the old school conservative literature. They say somewhere between 10 and 12%. So that's pretty high. I agree. It's not really that high. But again, a lot of that has to do with deformity, the implants that were used in the day, the plates, right? If we have a little bit more attention to how the plates they are next to degenerative levels. I think we're a little bit more aggressive now with treating or degenerative levels pre-op. What is your opinion, Dr. Garcia? What is your opinion for hybrid constructs versus disc replacement versus ACF? This is interesting. Yeah. This was kind of I saw people doing this maybe like 5 to 8 years ago. Um, and what this would be like, let's say you have three degenerative levels, right? One is really symptomatic, and then the other two are kind of in between, right? Whereas you're kind of like you don't really want to operate on them, but you know that if you do ACF at that middle level, the other two are going to break down for sure, right? So I saw a lot of people doing like ACDF disc replacement or ACDF in the middle and disc replacement above and below. That to me was very aggressive, and I would argue that I just didn't see the data supporting that. I didn't see any really real papers. These are all super low patient cohorts and very few all retrospective studies. And so it was hard to really draw any conclusion. It's interesting though, but I would argue that look, you have like you have something that's really no different from ACD. These two things, these two treatment options are really no different from each other, right? Does it really matter? No. If you do like, disc replacement ACDF versus a 3-level ACDF, same thing, you know? Okay. Based on your experience, which has shown the best outcomes? I would say um, best outcomes by far ACDF. I'd say by far ACDF, but that's personal bias, and that's purely patient selection because you can basically do an ACDF in anybody, right? You're not like looking at set arthropathy, you're not looking at spondylotic. ACDF will treat all that stuff, right? And it's good for all that stuff. Disc replacement, they're very highly select patients that that I do that on, and yes, they do well, but can I would I have done an ACF on those patients? Yeah, maybe I could have done that. So I haven't compared those two. I will say though, the few patients that are such consistent home runs are the post-cervical foraminotomies. I think that's such a great surgery. It's so underutilized. Those patients do really fantastic. There was a study, I'm blanking on the name of it. I want to say it was called the Return to Play study that came out probably about 10 years ago, where they compared ACF to post-cervical foraminotomy. And what they found was um, uh, slightly better at 1 year, slightly better radiculopathy outcomes, but more the results of ACF were more longer lasting as compared to post-cervical foraminotomy. There's more revisions of post-cervical foraminotomy versus ACF. And that could just be a technical aspect because the patients are great. Yeah. Okay. Very good. Um, I want to go back to one thing before I call it a night. I want to go back again. I talked about it a million times, but it's so important. If there are two papers you're going to read here, okay, this is my favorite disc replacement um, paper of all. This is the best paper. The Mraz paper is one of the best. This really goes through nuance and in detail. Like if you take out these conflict of interest papers, there's just like no difference in these things. So you can see how these papers are designed. And a lot of things I talked about are from that paper. And then the one I cited earlier in this, I guess you can watch the video. looking at study fragility with ACDF and disc replacement. That can be translated out to almost any paper in spine, looking at how fragile those studies are. Like it literally, it takes like 2 patients, 4 patients actually, that's the number. 4 patients in any group to totally change your results. It's unbelievable, right? So like, how do you draw any firm conclusions from these things? It's crazy. So I'm gonna pull it up here so you can, of course, like, probably at the beginning of my paper, but here we go. Yeah, so this is the one. So definitely look at this one and look at the Miraz paper. Those are my these are my two favorite papers in the disc replacement and ACDF literature. All right, so no more questions. We're ending a little early, which is fine. I hope you all have a great night, and I thank you for joining this latest edition of Virtual Global Spine. And I hope to see you next week.
Hey, Jonathan.
Yes.
Can you hear me? It's a good one.
Hey, what's going on, man?
I'm driving, so you might be a little hard to. It might be kind of hard to hear. Sorry about that. I just wanted to say, fantastic talk. I will probably be referring people to this talk when it's posted because this is like, you and I have read a lot of the same stuff, obviously, and arrived at very similar conclusions. And it's amazing to me. I wonder where we're going to go with a lot of this because it's amazing when I meet people that are 15 years out, and there are people out there who were early adopters and then kind of started thinking, I don't know that things are that different, and then kind of drifted back away from it. So I thought you described a lot of that quite well. So I just want to say thanks for putting this together. This was just outstanding.
Well, my pleasure. I'm glad you liked it. Any other questions? No? All right. If that's not, then we'll call it a night. Hope you all have a great night, and I will see you next week. Thank you so much for joining us today.